Welcome to the lecture entitled The Anatomy of Respiration, the second section of the three-part series on the thoracic wall. My name is Carlos Andres Suarez-Quian. I am the creator and narrator of this lecture. Let's begin. Previously, we discussed how the thoracic cage offers protection to the internal organs of the chest and parts of the abdomen. In this lecture, we will discuss the second function of the thoracic cage and learn how the bones and muscles help us breathe. The objectives for this lecture are listed here. There are three. First, I will describe how the thoracic cage aids in respiration. Second, I will name the three layers of intercostal muscles and explain their function in respiration. Third, I will again describe the position of the intercostal vessels and nerves with respect to the ribs to appreciate how to avoid injuring them when placing a chest tube or gaining access to the chest cavity. We start the lecture once again by identifying the thorax. It is here that we will find the lungs that will expand into the thoracic space when we breathe. We're looking at a lateral view of the thorax. Superiorly, the space is defined by the clavicle, anteriorly by the sternum, laterally by the ribs, inferiorly by the diaphragm, and posteriorly by the thoracic vertebrae. Housed within the thoracic cavity are the lungs, the organs responsible for oxygen exchange with the blood. The goal of respiration is to increase the volume of the thoracic cavity housing the lungs. The lung is attached to the thoracic cage by surface tension, specifically to the endothoracic fascia lining the thoracic cage. Hence, increasing the thoracic cage in size passively leads to lung expansion and filling with air. The dimensions of the thoracic cage that need to increase include the vertical dimension, and this is done by contracting our diaphragm, indicated in the left panel. This is the most important dimension and the one that changes the most when we breathe. Second, we increase our anterior-posterior dimension between the thoracic vertebrae and the sternum. This is accomplished by moving the ribs in an upward direction when we inhale. The ribs act similar to a lever and move the sternum anteriorly. And third, the horizontal spaces increase because as the ribs move upwardly, they also increase the axial dimension of the thorax. Think of a bucket handle. When the bucket handle is raised, a gap is formed between the handle and the rim of the bucket. The same thing happens in the thorax and the elevation of the ribs, leading to an increase in the horizontal dimension. We now define the muscles responsible for rib and sternal movements. Looking from the anterior view, if we remove the skin, the first muscle we encounter is the pectoralis major. If this muscle is reflected, we demonstrate the pectoralis minor, deep to the major, and laterally the serratus anterior. During normal respiration, these muscles do not contribute to rib movements per se, but hold on, we will see in a second when we do use them when we breathe. We repeat the same exercise, this time on the skin of the back, where it is removed and reveal two large muscles of the back, the trapezius and the latissimus dorsi muscles. And when we reflect the trapezius muscle, we demonstrate the levator scapulae, the rhomboid major, and the rhomboid minor. Let me say right off the bat that these are not muscles of respiration, that they help move the limbs, and we will study them when we study limb movement. I mention them here simply because they're located in the thoracic region, albeit on the back. The next set of muscles I need to discuss are the intercostal muscles. On the left, I am showing you a thoracic cage where the pectoralis major and minor and the serratus anterior muscles were reflected. On the right, I show you the posterior view of the thoracic cage after it was removed. In these dissections, the muscles that truly move the ribs during respiration are exposed, the intercostal muscles. And yes, they look just like short ribs because short ribs are intercostal muscles. On the left panel, we see the muscles as they appear on an anterior view of the ribs. And on the right panel, we see the intercostal muscles as we were looking at the ribs from behind. The large vessels you see running just parallel to the sternum are the internal thoracic arteries. The intercostal muscles are arranged as layers around the ribs, and muscle fiber orientation is quite specific. To better explain the arrangement of the intercostal muscles, let me show you them in drawings. Look, for example, at the external intercostal muscle layer. The muscle fibers extend from just lateral to the vertebrae to approximately a few inches before the costal cartilages form. Where the muscle fibers end anteriorly, a tendinous band continues to the sternum. But note also that the muscle fibers have been drawn only to fill the first three intercostal spaces. Realize that the external intercostal muscles extend to the 12th rib. The fibers of the external intercostal muscles are oriented obliquely downwards, like when you put your hands inside your pant pockets. Next, we focus our attention on the internal intercostal muscles and see that the muscle fibers are perpendicular to the orientation of the external intercostal muscles. Again, realize that the muscle layer fills in all intercostal spaces. Only part of the spaces have been filled in to simplify the image. The internal intercostals do extend to the sternum, but not to the vertebrae. We finally reach the third layer, the innermost intercostal muscles. The fibers have the same orientation as the internal intercostals. In addition, we encounter two other muscles somewhat inconsistent in location, the subcostal and the transversus thoracis. Understand that in this image, half of the rib cage was removed. You're looking at the inner space of the innermost muscles and some of the investing transversus thoracis. That the muscles truly form a circular band of layers can be best appreciated in a horizontal slice through the thorax, now shown in the drawing. The extent to which the external intercostal muscle reaches from the sternum to the vertebrae can also be discerned. Note, the medialmost part of the muscle layer consists of a membrane, whereas the internal intercostal muscle is just deep to the external intercostal membrane, and there is an internal intercostal membrane where the external intercostal muscle is located. The third layer is similarly arranged. All this, by way of strengthening the bands of muscles, help keep our ribs aligned and help perform the important function of respiration. So how do we breathe? The first thing that happens is that the diaphragm contracts, and as it does, the vertical dimension of the thoracic cavity increases. Concomitantly, the external intercostal muscles contract also and move the sternum anteriorly, expanding the anterior-posterior dimension of the thoracic cavity. But does this not make you wonder why the contraction of the muscle does not just simply narrow the intercostal gaps, instead of making the ribs work as levers for the sternum? The answer is simple. Muscles attach to the first rib and hold these ribs in place, not allowing them to move inferiorly. Hence, with the first rib serving as an anchor, the rest of the ribs are now elevated and indirectly elevate the sternum. While the ribs are being raised, they're also moving laterally, outwards from the body wall, what we mentioned previously as the bucket handles. In effect, the concerted actions of the external intercostal muscles have elevated and laterally expanded the rib cage. Look at yourself in the mirror and confirm these actions. Breathing, then, occurs because the thoracic cavity expands in volume and the lungs fill with air. Once we reach the ability of the lungs to expand to its normal capacity, the chest contracts passively. That is, the diaphragm returns to its normal position and the air exits the lungs. The expiration phase entails the action of the internal intercostals. In this case, the 12th rib must be anchored in place for the internal intercostals to function. The anchoring of the rib is done by a muscle called the quadratus lumborum. We will see this muscle when we dissect the back. What has just been described is referred to as quiet inspiration. The fancy term for this is apnea. It may also be referred to as diaphragmatic breathing, given that the muscle responsible for the greatest increase in size to the thoracic volume during normal breathing is the diaphragm. Here again we see the external intercostal muscles and the scalene muscles that help anchor the first two ribs to permit elevation of the ribs and sternum during inspiration. The arrow indicates the contraction of the external intercostal muscles. But what happens in women who are pregnant and the uterus prevents an increase of the chest cavity? The diaphragm contracts but cannot move downwards. In this case, the diaphragm will contribute very little, if any, to an increase in thoracic volume, and now women depend solely on the action of the intercostal muscles. Indeed, in pregnant women, any muscle that is attached to the ribs and can aid in the raising of the ribs will help in respiration. Here, for example, we show the pectoralis minor helping with respiration, and the serratus anterior muscle also helping with respiration. However, this too would be considered apnea, that is, quiet inspiration. And, as before, quiet expiration is accomplished either by the passive recoil of the lung and or the action of the intercostal muscles depressing the ribs. If we have quiet inspiration, then by definition we must also have forced breathing involving active inspiratory and expiratory movements. If you have ever placed your hands on your knees after a run, as now being shown, or raised your arms above your head and crossed them, then you are engaging in gasping breathing or forced breathing. In this case, not only will you recruit all the muscles that help you with quiet inspiration, but now you will also deploy the pectoralis major, the pectoralis minor, and the serratus anterior. It is for this reason that these muscles are termed accessory muscles of respiration. And with forced respiration comes forced expiration, in which not only the internal intercostals will be used, but also the abdominal muscles as well. I am sure you have seen movies where women in labor are encouraged to push. It is the same action, and they're using these muscles to force air out of their lungs as well. There's a special case where breathing is difficult to perform. In fact, it is not considered true breathing. This is called agonal breathing, the medical term used to describe struggling to breathe or gasping. It is often a symptom of a severe medical emergency, such as stroke or cardiac arrest. The gasping associated with agonal breathing represents a brainstem reflex and would not appear normal even to an inexperienced student seeing it for the first time. As we mentioned in the previous section of this lecture series, the intercostal muscles are innervated by the segmental intercostal nerves. The corresponding vein, artery, and nerve have a special relationship within the intercostal space. Look closely at the drawing on the right and the location of where the nerve, artery, and vein run in the intercostal space relative to the muscles. The sternum and vertebrae are labeled to indicate anterior and posterior locations, respectively, as well as the external intercostal muscles. The intercostal nerve, artery, and vein run in between the innermost intercostal and the internal intercostal muscles. The space between these muscles allows for the neurovascular bundle to run here. In the dissection on the left, the neurovascular bundles are clearly evident with respect to their relationships to the corresponding ribs. Let's examine the relationship of the vein, artery, and nerve to the rib once again, as now shown in the drawing. Ribs and the reflected external and internal intercostal muscles are labeled. Now I am labeling the internal and innermost intercostal muscles. The neurovascular bundle is now indicated, and look at the order from top down. The vein, artery, and nerve run from top to bottom, just deep to the internal intercostal muscle and precisely inferior to the corresponding rib. And why will you need to tattoo this clinical pearl in your memory forever? Perhaps someday you will need to perform a pleural tap to remove fluid from the pleural cavity of a patient or insert a chest tube to save a life. You will want to introduce the needle or trocar above the rib, not below it, to avoid injuring the neurovascular bundle. I should mention that the accessory neurovascular bundle, shown here, is not meant to confuse you. It is simply a reminder that accessory nerves do exist in this area also, but are small and rarely injured by the needle or trocar being introduced. This now concludes the second section of the lecture on the thoracic cage.